All right, let us continue. If you're able to hear me, raise your hand. All right, next we'll be looking at chapter 34, Pediatric Emergencies. It's a very lengthy chapter. It's unlikely that I'll be able to finish it before lunch, or today. However, for this particular chapter, a lot of the emergencies that you have been studying up to this point have segments that focus on pediatric and geriatric population. If you have been paying close attention to those areas in the previous chapters, then you might not be required to do a lot of reading for this particular chapter. So when you go through pediatric emergencies, your goal is to identify what is different in comparison to the adult or geriatric population. So what is different is what you need to retain. Introduction. Children differ anatomically, physically, and emotionally from adults. Illnesses and injuries that children sustain and their responses to them vary based on age or their developmental level. Important to remember that children are not small adults. Fear of EMS providers and pain can make the child difficult to assess. Once you learn how to approach children of different ages and what to expect while caring for them, you will find that treating children also offers some very special rewards. Communication with patient and the family. When caring for a pediatric patient, you must care for parents or caregivers as well. Caregivers often need emotional support. A calm parent usually results in a calm child. An agitated parent means a child will act in the same manner. Remain calm, efficient, professional, and sensitive. Now, the growth and developmental stages is very important. So this is something that you must know for exam purposes. Growth and development. Many physical and emotional changes occur during childhood, birth to age 18. Thoughts and behaviors. Thoughts and behavior. Infancy, first year of life. Toddler, 1 to 3 years. Preschool age, 3 to 6 years. School age, 6 to 12 years. Adolescent, 12 to 18. The infant. Infancy is defined as first year of life. First month after birth is neonatal or newborn period. 0 to 2 months. They spend most time sleeping and eating. They sleep up to 16 hours a day. Respond mainly to physical stimuli. They cannot tell the difference between parents and strangers. Crying is one of their main modes of communication. 1 second. Right, and I'm back. 0 to 2 months, basic needs, food, warmth, and comfort. Soothing includes holding, cuddling, or rocking. Hearing is well developed at birth. Calm, reassuring talk is helpful and helps to soothe the infant. They have a sucking reflex for feeding. Head control is limited. They are predisposed to hypothermia, so they lose body heat quickly. They may need to unbundle the infant, during assessment. At 2 to 6 months, they are more active. At this stage, they are a little easier to evaluate. They spend more time awake. They smile, they make eye contact, they recognize caregivers. They have a strong sucking reflex. Their extremities are very active, and they have a strong cry. They may follow objects with their eyes. 2 to 6 months continued, there's an increased awareness of surroundings. They will use both hands to examine objects. About 70% of infants will sleep through the night by 6 months. They begin to roll over at this stage. Their persistent crying, irritability, or lack of eye contact can be an indicator of a serious problem, depressed mental status, or delay in their development. At 6 to 12 months, infants begin to babble, say their first word by their first year, learn to sit without support, begin to crawl, and finally walk. And because they are moving now, it predisposes them to physical dangers. And they're top heavy, so if they fall, they're gonna fall head first. At 6 to 12 months continued, they begin teething and exploring their world by putting objects in their mouth. So this put them at risk for airway obstruction and poisoning. May cry if separated from parents or caregivers. It's called separation anxiety. Assess with caregiver nearby. Persistent crying or irritability can be symptoms of a serious illness. Assessment. Observe infant from a distance. Caregiver should hold baby during physical assessment. Provide sensory comfort, warm hands, and the end of stethoscope. Do painful procedures at the end of the assessment. Now let's look at the toddler. After infancy until 3 years of age, a child is called a toddler. They experience rapid changes in growth and development during this stage. At 12 to 18 months, they begin to walk and explore their environment. They are able to open doors, drawers, boxes, and bottles. At 12 to 18 months continued, because they are explorers by nature and they are not afraid, so they are quite fearless at this stage, injuries will increase. Begin to imitate behaviors of older children and parents. They know major body parts. They may speak 4 to 6 words. They may not be able to fully chew food, again putting them at risk for airway obstruction. At 18 to 24 months, the mind develops rapidly at this stage. Their vocabulary increases significantly to about 100 words. They're able to name common objects. They begin to understand cause and effect. Balance and gait improve rapidly. Running and climbing skills develop. They may cling to parents or comforting toy. Use any comforting objects when available. Now your assessment of the toddler. They may have strange anxiety. They may resist separation from caregiver. They may have a hard time giving a description of pain. They can be distracted. Begin your assessment from the feet. Persistent crying can be a symptom of serious illness or injury. Previous medical experience may lead to hesitation toward you. So one of the key things you need to note on this slide is that the assessment starts from the feet up. Now, the preschool age child, age 3 to 6 years, able to use simple language effectively. Most rapid increases in language occurs at this stage. They can walk, they can run well, they begin throwing, catching, and kicking during play. Toilet training is mastered. They have a rich imagination and can be fearful about pain. They may believe injury is a result of earlier bad behavior. Learn which behaviors are appropriate and inappropriate. Foreign body aspiration, airway obstruction is still a high risk. Assessment can understand directions and be specific in describing painful areas. Much history must still be obtained from caregivers. Be simple and direct with your communication. Appealing to the child's imagination may facilitate an examination process. Never lie to the patient. Patient may be easily distracted. Again, begin your assessment at the feet, moving to the head. So for toddlers, below toddler level, for toddlers, preschool, we want to start the assessment from the feet and move towards the head. Use adhesive bandages to cover the site of an injection or other small wound. Modesty is developing. Keep child covered as much as possible. Now, school age years, this is 6 to 12 years. They begin to act more like adults at this stage. They can think in concrete terms. They can respond sensibly to questions. They can help take care of themselves. School is important. Children begin to understand death. Assessment. Assessment begins to be more like adults. To help gain trust, talk to the child, not just the caregiver. Start with the head and move to the feet if possible. Give the child choices. Ask only the type of questions that let you control the answer. Do not bargain or debate with the patient. Allow the child to listen to his or her heartbeat through a stethoscope. Can understand the difference between physical and emotional pain. Provide simple explanation about what is causing their pain and what will be done. Ask parents or caregivers advice about which distraction will work best. Now your adolescents, 13 to 18 years. They're able to think abstractly and can participate in decision making. Personal morals begin to develop. They are able to discriminate between right and wrong. They are able to incorporate values into decision making. Their physical traits are similar to an adult's, shifting from family to friends for support. Interest in romantic relationships begin at this stage. Puberty also begins. Very concerned about how their body looks and their appearance. There's a strong feeling of privacy, the need for privacy. It's an experimental phase, so time of experimentation and risk-taking. They often feel indestructible. They struggle with independence, loss of control, body image, sexuality, and peer pressure. They may have mood swings and they can develop depression. Your assessment can often understand complex concepts and treatment options. Allow them to be involved in their own care, provide choices while lending guidance. EMT of the same gender should do physical examination if possible. Allow them to speak openly and ask questions. Risk-taking behaviors are common, can ultimately facilitate development and judgment and shape identity. Can also result in trauma, dangerous sexual practices, and teen pregnancy. Female patients may be pregnant. Important to report this information to the receiving facility. Adolescent may not want parents to know this information. Try to interview without the caregiver or parent present. Have clear understanding of pain. They get them talking to distract them. Now let's look specifically at the anatomy and physiology. We just look at the developmental age, and it's really nothing new because we looked at lifespan development in the, I believe it was the first week of the course. All of the information that was in lifespan development is the same for the first part of your pediatric chapter. Anatomy and physiology. Body is growing and changing very rapidly during childhood. You must understand the physical differences between children and adults and alter your patient care accordingly. So this part is very important. We need to understand the differences in your anatomy. So anatomy of the airway differs from adults. The pediatric airway is much smaller in its diameter, it's shorter in length. The epiglottis is bigger. Their air passage is very narrow. Their lungs are smaller. Their heart is higher in the chest. Now, based on the differences in their airway, or respiratory system, it puts them at a high risk for airway obstruction, especially the younger pediatric population. The glottic opening is higher and positioned more anteriorly, and the neck appears to be non-existent. As a child develops, the neck becomes proportionally longer as the vocal cords and epiglottis achieve anatomically correct adult position. Oops. All right, we're good. Their occiput is larger or rounder, and that's the posterior portion of their head. Proportionally, they have a large tongue. The epiglottis is long, floppy, and it's U-shaped. There's less development in the rings of the cartilage, or less developed rings of cartilage in the trachea. There is narrowing, funnel-shaped upper airway. All of these things that are listed on this slide, all it is saying is they're at a high risk for airway obstruction. Airway. That's pediatric. Diameter of the trachea in infants is about the same as a drinking straw, quite narrow. Airway is easily obstructed by secretions, blood, or swelling. Infants are nose breathers and they may require suctioning and airway maintenance. We learned this previously. So if you're going to suction a newborn, you suction the mouth first, then the nose. The respiratory rate of 20 to 60 breaths per minute is normal for a newborn, and we really want it on the higher end than the lower end. Children have an oxygen demand that is twice that of an adult. Therefore, they are at a significant risk of developing hypoxia. The younger pediatric population relies more heavily on the diaphragm to breathe. So muscles of the diaphragm dictate the amount of oxygen a child inspires. Pressure on the child's abdomen can cause respiratory compromise. Use caution when applying straps of a spinal immobilization device. Gastric distension can interfere with movement of the diaphragm and lead to hyperventilation. So if their stomach becomes distended, it can cause the diaphragm to shift upward, and that can interfere with their tidal volume, which can lead to hyperventilation. Breath sounds are more easily heard in children because of their thinner chest walls. Detection of poor ear movement or complete absence of breath sounds may be more difficult. Now let's look at the circulatory system. Important to know normal pulse ranges. So the infant heart can be 160 beats per minute or more. Should not be less than 100. And if it's below 60, they need compression. Primary method used to compensate for decreased perfusion. So they rely heavily on their circulatory system to compensate for shock. So you will see tachycardia, 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 bradycardia, death. Right? If you see bradycardia, they're extremely close to death. Children are able to compensate for decreased perfusion by constricting vessels in the skin. Blood flow to the extremities can be diminished. Signs of vasoconstriction include pallor, which is an early sign, weak distal pulses in the extremities, delayed capillary refill, and cool hands or feet. The nervous system. The pediatric nervous system is immature and underdeveloped and not well protected. Their head to body ratio is large, meaning their head is much heavier than the rest of their body. The occipital region of the head is larger, especially for your younger pediatric population. Subarachnoid space is relatively smaller, leaving less cushioning for the brain. Brain tissue and cerebral vasculature are fragile and prone to bleeding from shearing forces. Pediatric brain requires a higher cerebral blood flow, oxygen, and glucose. At risk for secondary brain damage from hypertension and hypoxic events. Spinal cord injuries are less common. If injured, it is more likely to be an injury to the ligaments because of a fall. For suspected neck injury, perform manual inline stabilization or follow local protocols. Now, let's look at the gastrointestinal system. Abdominal muscles are less developed. There is less protection from trauma. The liver, spleen, and kidneys are proportionally larger, and they are more anterior, right? So they are proportionally larger. They take up more space in their abdomen, and they are more anterior, which puts them at a risk for injury. And these are vascular organs, so they can bleed quite significantly. So there is a higher risk for multiple organ injury. The musculoskeletal system. Open growth plates allow bones to grow. So the bones grow from what we call the epiphyseal plate. And bone growth takes place in the stages of development till we get close to adolescent, or sorry, until they get to the adolescent phase where they fuse completely. Now, once they're at a stage where the bone is still growing, wherever the growth plate is going to be the weakest point of the bone. So it's going to be the area of the bone that is prone to fracture. And if a fracture occurs at the growth plate, it can also interfere with how the bone grows and they can have permanent deformity where one limb is longer than the other. As a result of growth plates, children's bones are softer and more flexible, making them prone to stress fracture. Bone length discrepancies can occur if injury to the growth plate occurs. Immobilize all strains and sprains. Bones of an infant's head are flexible and soft. Soft spots are located at the front and back of the head, referred to as fontanelles. They will close at particular stages of development, and usually they should all be closed by the time they reach 2 years of age. Fontanelles of an infant can be a useful assessment tool. So you always examine the fontanelles of an infant. If it's bulging out, that's overhydration. If it's being pulled or look as if it's sinking in, that's dehydration. Thoracic cage is highly elastic and pliable, composed of cartilaginous connective tissue. The ribs and vital organs are less protected. So because of how pliable and elastic their thoracic cage is, put them at a high risk for internal injuries. Integumentary system, pediatric system differs in a few ways. Thinner skin, less subcutaneous fat. Composition of skin is thinner and tends to burn more deeply and easily with less exposure. There's a higher ratio of body surface area to body mass, which leads to larger fluid and heat losses. So the skin can cut easily. They can lose heat very quickly. They can lose fluid very easily. And if they get burned, it's going to be quite severe for them. All right, now let's look at the patient assessment. Starting with the scene size up. Assessment begins at the time of dispatch. So you need to mentally prepare yourself for a pediatric case. It is a difficult case if it's a true emergency. So mentally, you have to be prepared for it. Prepare mentally for approaching and treating an infant or child. Plan for pediatric size up, equipment, and age-appropriate physical assessment. And we usually have protocols and assessment tools for this, because if you're not seeing pediatric patients often, you're not going to be readily remembering the differences or what type of equipment you should be using for which age group. So we have protocols that guide us, and we have special assessment type tools like resuscitation tape, Breslow tape, that we can use to give us a quick reminder in terms of what is necessary for this child based on their size and age of development. Collect age and gender of the child, location of scene, nature of illness or MOI, and chief complaint from dispatch. Scene safety, ensure proper safety precautions and standard precautions. Note position in which patient is found. Look for possible safety threats. Patient may be safety threat if he or she has an infectious disease. Do an environmental assessment. This will provide important information. Inspect the physical environment. Information from parents or caregivers is important, and it may provide clues to what is wrong with the patient. Document dangerous scenes, scene conditions, and inappropriate statements from caregivers or even parents. Traumatic scene where the child is unresponsive or too young to communicate. Assume the injury was significant enough to cause a head or neck injury. Perform cervical spine immobilization if suspected MOI is severe. Pad under the child's head and or shoulder to facilitate a neutral position for airway management, especially in your younger pediatric age group, like your preschool down. After the scene size up, the next phase is a primary assessment. Now, the difference between their primary assessment and the adult is we perform what is called the PAT assessment or PAT triangle. We think about the PAT triangle or pediatric assessment triangle. So this is what we use to determine their general impression. So you observe them and you're looking at their appearance, their work of breathing, and circulation. It does not require you to touch the patient, and it can be performed within less than 30 seconds. So PAT does not require equipment. It has 3 steps: appearance, work of breathing, circulation. For appearance, note their level of consciousness, how they interact with caregivers and parents, muscle tone, activity. You can use the AVPU scale modified as necessary for the pediatric patient's age. Normal level of consciousness, they should act appropriately for their age group. They should exhibit good muscle tone, and they should be able to maintain good eye contact. Use the Tickles mnemonic to determine if they are sick or not sick. So the Tickles mnemonic look at tone, interactiveness, consolability, look or gaze, speech or cry. Now, the work of breathing increases as the body attempts to compensate for abnormalities in oxygen and ventilation. May manifest as abnormal airway noise, accessory muscle use, retractions, head bobbing, nasal flaring, tachypnea, and tripod position. C is the circulation to the skin. Right? So circulation circulation to the skin. When cardiac output fails, the body shunts blood from areas of lesser need to areas of greater need. Pallor of the skin and mucous membranes may be seen in compensated shock. Mottling is a sign of poor perfusion, where the skin looks patchy and feels sticky. Cyanosis reflects decreased level of oxygen. A delayed capillary fill is a significant finding for your pediatric population. From the pediatric assessment triangle findings, you will decide if your patient is stable and requires urgent care. If you think they are unstable, then you will immediately move into your assessment of the ABCs, treat life threats, transport immediately. With life-threatening external hemorrhages, assess and address CABs first, including tourniquets if necessary. If stable, continue with the remainder of the assessment process. So after we have used the pediatric assessment triangle to do a general impression by looking at appearance, work of breathing, and circulation to the skin, we will perform the hands-on ABCs, A, B, C, D, E actually. And this assessment can also be used for adults. A matter of fact, this is the way that emergency physicians assess patients. So an ER physician, this is their assessment style. Airway, breathing, circulation, disability, exposure. Right? Now, what you wouldn't be familiar with is the disability and exposure, but technically, we have been focusing on this method of assessment. So what you have learned previously is to assess airway, assess breathing, assess circulation. But I kept saying to you that once you have completed circulation, you would know the patient's GCS, whether you need to do a rapid scan or focus, whether you need to do a load and go or stay and play. The disability, or D, looks at the patient's GCS or neurologic assessment. So that's what disability is. The exposure, just think of that as you're doing a rapid scan. So technically, it's the same assessment. So hands-on ABCs. For pediatric patient, you will now perform a hands-on ABCs assessment after you have done your PAT. Assess and treat any live threats as you identify them by following the ABCDE format. Airway, if airway is open and will remain open, assess respiratory adequacy. If the patient is unresponsive or has difficulty keeping airway open, ensure it is properly positioned, clear of mucus, vomitus, blood, and foreign bodies. You will use the head tilt, chin lift, or jaw thrust maneuver or modified techniques. Always position airway in neutral sniffing position for your smaller pediatric population. This will prevent their airway from kinking because of how narrow it is and maintains proper alignment. Establish whether patient can maintain his or her own airway. Breathing, use the look, listen, feel technique. Nothing new here. Place both hands on the patient's chest to feel for rise and fall of the chest wall. Belly breathing in infants is considered adequate because they rely more on their diaphragm. Bradycardia is an ominous sign and indicates impending respiratory arrest. So if they're breathing slow, they're in trouble. Circulation. Determine if the patient has a pulse, is bleeding, or is in shock. In infants, palpate the brachial or femoral pulse. In children older than 1 year, palpate the carotid pulse if they are not communicating. Strong central pulses usually indicate that the child is not hypotensive. Weak or absent peripheral pulse indicate decreased perfusion. Tachycardia may be an early sign that their oxygen levels are low. Interpret pulse within the context of overall history, the PAT, and primary assessment. So you have to consider the history, the findings in your PAT and your primary assessment. We can't just focus too much on the pulse and develop tunnel vision. Evaluate trend of increasing or decreasing pulse rate. A decreasing pulse rate is not good for your younger pediatric population. Feel skin for temperature and moisture. Estimate capillary refill time. It's a very important assessment for your pediatric population. Disability, right? So disability, this is where they use the ABPU scale or pediatric GCS, and the GCS is going to be more commonly used at this point because some aspects of the ABPU would have already been completed. So it's really the GCS. And it's the same as I've said previously for your adult. After you have done your ABCs, you should know what your patient's GCS is. So use the ABPU scale or pediatric GCS. Disabilities and neurologic assessment. Check pupil response. Look for symmetric movement of the extremities. Pain is present with most types of injuries. Assessment of pain must consider your assessment of pain is going to be based on the patient's age of development. So GCS, neurologic assessment, neurovascular assessment will fall in disability. Exposure. Think of it as you're now doing a rapid scan. Hands-on ABCs require that the caregiver remove some of the patient's clothing for observation. Avoid heat loss by covering the patient as soon as possible. More prone to hypothermic events. Should be kept warm during transport. Now, after the ABCDEs, you make a transport decision. Determine whether rapid transport to the hospital is indicated. Rapid transport is indicated if there is a significant MOI, history compatible with serious illness, physical abnormality noted, potentially serious anatomic abnormality exists, significant pain is present, they have an abnormal level of consciousness. Also consider the type of clinical problem, the benefits of ALS treatment in the field, be guided by your local EMS protocol, your comfort level, transport time to the hospital. If patient's condition is urgent, initiate immediate transport to the closest appropriate facility. Transport decision continued. Less than 40 pounds, transport in a car seat. To mount a car seat to a stretcher, put head of stretcher upright, put car seat against the back of the stretcher, secure upper and lower stretcher straps through seat belt holes on the car seat, push seat into stretcher tightly and retighten straps. Follow manufacturer's instructions to secure car seat in captain's chair. Patients who require spinal immobilization, immobilize on a longboard or other suitable spinal immobilization device. Keep in mind that if they're on a spine board, it is very important that you limit their ability to shift on the board. Patients in cardiopulmonary arrest use a device that can be secured to the stretcher. You should not use the pediatric patient's own car seat. The goal is to secure and protect the pediatric patient for transport in the ambulance. Now, after the primary assessment, the next phase is your history taking. Approach to history depends on the age of the patient. History information for an infant, toddler, or preschool, you're going to get that from caregivers or parents. Adolescent information, you obtain that from the patient. Questioning the parents or child about immediate illness or injury should be based on the child's chief complaint. Questions to ask based on chief complaint, NOI or MOI, the length of their sickness or injury, key events leading up to the injury or illness, is a fever present? Are they having seizures as a result of the fever? Effects of illness or injury on behavior, the patient's activity level, recent eating, drinking, and urine output. Questions to ask. Are there changes in bowel and bladder habits? Is there vomiting, diarrhea, abdominal pain? Is there the presence of rashes? Obtain name and phone number of caregiver if they are not able to come to the hospital with you. Sample history, same as adult. Question based on age of developmental stage. Obtain OPQRST, same for children and adults. Question based on developmental stage. In your secondary assessment, physical examination, secondary assessment of the entire body should be used when patient is unresponsive or has a significant MOI. Use DCAP ETLS Mnemonic. Focus assessment should be performed on patients without life threats. Focus on areas of the body affected by injury or illness, as well as on the chief complaint, MOI or NOI, and the findings of the primary assessment. Infants, toddlers, and preschool age children should be assessed starting from the feet and ending at the head. Very important slide. Infants, toddlers, and preschool, we start the assessment from the feet and we'll move up to the head. School-age children and adolescents should be assessed using the head-to-toe approach. And The feet to head assessment is when they are responsive. If they are not responsive, is ABCs. So just keep that in mind. Head, look for bruising, swelling, and hematomas. Assess the fontanelles in infants. Nose, nasal congestion and mucus can cause respiratory distress, common in your younger pediatric population. Gentle bulb or catheter suction may bring relief. For ears, drainage from ears may indicate skull fracture. Battle sign may indicate skull fracture. The presence of pus may indicate infection. For the mouth, look for active bleeding and loose teeth. Note the smell of the breath. For the neck, examine tracheal area for swelling or bruising. Note if patient cannot move neck and has high fever. For the chest, examine for penetrating trauma, lacerations, bruises or rashes. Feel clavicles and every rib for tenderness and or deformity. For the back, inspect back for lacerations, penetrating injuries, bruises or rashes. Abdomen, inspect for distension, gently palpate and watch for guarding or tensing of muscles. Note tenderness or masses. Look for seatbelt abrasions or bruising. For the extremities, assess for symmetry. Compare both sides for color, warmth, size of joint, swelling, and tenderness. Put each joint through a full range of motion while watching the patient's eyes for signs of pain. Vital signs, some guidelines equipment used to assess adult circulatory status have limitations in pediatric patients. Normal heart rate vary with age in pediatric patients. The blood pressure is usually not assessed in patients younger than 3 years of age. Assessment of the skin is a better indication of the pediatric patient's circulatory status. When equipment is used, it is important to use appropriately sized equipment. Use a cuff that covers 2/3 of the pediatric patient's upper arm. Right? Now, use this formula to determine blood pressure for children ages 1 and 10 years. 70 plus 2 times the child's age in years equal blood pressure systolic. Respiratory rates may be difficult to interpret. Count respirations for at least 30 seconds and double that number. So 15 can be used for adult. We don't use 15 for the pediatric population. We use 30 for 1 minute. In infants and those younger than 3 years, evaluate respirations by assessing the rise and fall of the abdomen. So this is a very important slide, extremely important. A lot of information is on this slide. Pay attention to it. Assess pulse rate by counting at least 1 minute, noting quality and regularity. Normal pediatric vital signs vary with age. Assess respiration, then pulse, then blood pressure. Evaluate pupils using a small pen light. Compare size of pupils. Pulse oximetry is a valuable tool for patients with respiratory issues. Reassess the reassessment. Reassess the pediatric patient's condition as necessary. Obtain vital signs every 15 minutes if stable. Obtain vital signs every 5 minutes if unstable. Continually monitor respiratory effort, skin color, and condition, and the level of consciousness or interactiveness. Interventions. Parents or caregivers may be able to assist able to calm and reassure a child, often well versed on their child's medical condition, oxygen or nebulizer administration, communication and documentation, communicate and document all relevant information to ED personnel. All right, now respiratory emergencies. Respiratory problems are the leading cause of cardiopulmonary arrest in the pediatric population. Your inability to recognize and treat these respiratory emergencies can lead to death in the pediatric population. Patient must work harder to breathe and will eventually go into respiratory failure if left untreated. In the early stages, you may not note changes in behavior such as combativeness, restlessness, and anxiety. Signs and symptoms that will indicate an increased work of breathing include nasal flaring, whether or not abnormal sounds are present, accessory muscle use, tripod positioning. As a pediatric patient progresses to possible respiratory failure, their breathing effort will decrease, the chest will rise less with inspiration, the body has used up all available energy stores and cannot continue to support extra work of breathing. Without care, cyanosis will develop. As the patient progresses to possible respiratory failure, there will be changes in their behavior. Eventually, the LOC will be altered. The patient will have periods of apnea or periods where they stop breathing. The heart muscle becomes hypoxic. This leads to bradycardia. Bradycardia is not good in your younger pediatric population, so you need to contemplate CPR at this point. As the patient progresses to possible respiratory failure does not always indicate airway obstruction. Condition can progress from respiratory distress to failure at any time. Reassess frequently. And I've said this before, respiratory distress is defined as the patient being able to exhibit adequate chest rise. So once there is visible chest rise, it is distress if they're having complication. They don't have visible chest rise or poor chest rise, then they're going into failure. A child or infant needs supplemental oxygen. For infants and children in possible respiratory failure, assist ventilations with a BVM and 100% oxygen. Allow the patient to remain in a position of comfort. Right now, airway obstruction. Children can obstruct airway with any object they can fit into their mouth. In case of trauma, teeth may have been dislodged into the airway. Blood, vomitus, or other secretions can cause severe airway obstruction. Infections can cause airway obstruction. Infection should be considered if the patient has congestion, fever, drooling, cold symptoms. Croup is an infection in the airway below the level of the vocal cords. Epiglottitis is an infection of the soft tissues above the level of the vocal cords. So epiglottitis is above the vocal cords. Croup is below the level of the vocal cords. Obstruction by foreign object may involve upper or lower airway. Obstruction may be partial or it may be complete. Signs and symptoms associated with partial upper airway obstruction include decreased breath sounds and stridor. Infants or children with complete airway obstruction will not make any sound, have no breath sounds, and become rapidly cyanotic. Signs and symptoms of lower airway obstruction include wheezing and or crackles. The best way to auscultate breath sounds in pediatric patients is to listen to both sides of the chest at the armpit level. Important information. Immediately begin treatment of the airway obstruction. Encourage coughing to clear airway when patient is conscious and forcibly coughing. If this does not remove the object, do not intervene except to provide oxygen. Allow patient to remain in whatever position is most comfortable. If you see signs of severe airway obstruction, attempt to clear the airway immediately. You're looking for ineffective cough, no sound, inability to speak or cry, increasing respiratory difficulty with stridor, cyanosis, or loss of consciousness. If an infant is conscious with a complete airway obstruction, perform up to 5 back blows followed by chest thrust. These are things that we have gone through before. Position the infant face down on your forearm and slap the back forcefully 5 times. The airway does not clear, flip the child onto his or her back and perform up to 5 chest thrusts in the same manner you would for CPR. Repeat the process until the obstruction clears or until the infant becomes unconscious. If a child is conscious with complete airway obstruction, perform abdominal thrusts. Continue until the obstruction is relieved or until the child loses consciousness. Use head tilt chin lift and finger sweep to remove a visible foreign body in an unconscious pediatric patient. Use chest compression to relieve a severe airway obstruction in an unconscious pediatric patient. Increased pressure in the chest creates an artificial cough. Asthma, a condition in which the bronchioles become inflamed, swell, and produce excessive mucus, leading to difficulty breathing. It's a true emergency if not promptly identified and treated. 10% of US children are affected. Common cause of asthma attack include a upper respiratory tract infection, exercise, exposure to cold air or smoke, and emotional stress. Signs and symptoms: wheezing as the patient exhales. In some cases, airway is completely blocked and there is no ear movement heard when you auscultate. Cyanosis and respiratory arrest may quickly develop. Tripod position allows for easier breathing. Treatment: allow the patient to assume a position of comfort. Administer supplemental oxygen. They will benefit from a bronchodilator via metered-dose inhaler with a spacer, mask device if protocol allows, or nebulization. If assisting ventilation, use slow, gentle breaths. Resist temptation to squeeze the bag hard or fast because you can create a pneumothorax. A prolonged asthma attack may progress into status asthmaticus, which is a true emergency. This is an asthmatic attack that does not improve with conventional treatment. Administer oxygen and provide rapid transport if patient becomes exhausted and stops struggling to breathe. Manage their airway aggressively. Give oxygen, transport promptly. Consider ALS. Pneumonia, leading cause of death in children. Pneumonia is a general term that refers to an infection of the lungs. It's often a secondary infection, can also occur from chemical ingestion. Diseases causing immunodeficiency in children increase their risk for pneumonia. Incidence is greatest during fall and winter months. Presentation in pediatric patient: unusual rapid breathing, sometimes with grunting or wheezing sounds. They will have nasal flaring, tachypnea, hyperthermia, or fever. They'll have unilateral diminished breath sounds or crackles over the infected lung segment. Pediatric patient treatment for pneumonia. Primary treatment will be supportive. Pay attention to their airway and breathing. Give supplemental oxygen. Humidified oxygen will be beneficial once it's a infection or respiratory tract infection. If the child is wheezing, administer bronchodilator if permitted, whether it's a meter dose or nebulization. Diagnosis of pneumonia must be confirmed in the hospital setting. Croup is an infection of the airway below the level of the vocal cords. It's usually by a virus, and they will have a low-grade fever, typically seen in children between 6 months and 3 years. It is easily spread between children. The disease starts with a cold, so it presents just like cold-like symptoms, cold, cough, and a low-grade fever that develops over 2 days. The hallmark sign of croup is stridor and a sealed bark cough. Treatment. Croup often responds well to administration of humidified oxygen. Bronchodilators are not indicated for croup and can make the child worse. Epiglottitis. This is a bacterial infection of the soft tissues in the area above the vocal cords. It's a bacteria, so they're going to have a high fever. Incidence decrease since development of vaccine. The epiglottis can swell to 2 or 3 times its normal size. The children will look ill. They report a very sore throat and have a high-grade fever. They will be in the tripod position and they will be drooling. Common. Bronchiolitis, specific viral illness of newborns and toddlers, which is often caused by the respiratory syncytial virus or RSV. Causes inflammation of the bronchioles. RSV is highly contagious and spread through coughing or sneezing. The virus can survive on surfaces. The virus tends to spread rapidly through schools and childcare centers. More common in premature infants and result in copious secretions. It occurs during the first 2 years of life, more common in males. Most widespread in winter and early spring. The bronchioles become inflamed, swell, and fill with mucus. Airways can easily become blocked. Look for signs of dehydration, shortness of breath, and fever. Treatment for bronchiolitis. Use calm demeanor when approaching. Allow the patient to remain in a position of comfort. Treat airway and breathing problems. Humidified oxygen is helpful. Consider ALS backup. Now, pertussis or whooping cough. Pertussis or whooping cough is caused by a bacterium spread via the respiratory droplets. It's less common in the United States. Signs and symptoms: coughing, sneezing, and a runny nose. The coughing becomes more severe with a distinctive whoop sound during inspiration. Right? And it's going to take a while for this cough for them to get rid of this cough. Infants may develop pneumonia and respiratory failure. To treat pediatric patients, keep the airway patent and open and transport. Pertussis is contagious, so follow standard precautions, including wearing a mask and eye protection. Airway adjuncts. Devices that help to maintain the airway or assist in providing artificial ventilation. Includes oropharyngeal and nasopharyngeal airways, bite blocks, BVMs. Oropharyngeal airway keeps the tongue from blocking the airway and makes suctioning easier. Should be used for pediatric patients who are unconscious and in respiratory failure. Should not be used in conscious patients or those who have a gag reflex or who may have ingested a caustic or petroleum-based product. Nasopharyngeal airway, usually well tolerated, used for responsive pediatric patients, used in association with possible respiratory failure. Rarely used in infants younger than 1 year. Should not be used if there is nasal obstruction or head trauma. Nasopharyngeal airway potential problems. It may become obstructed by mucus, blood, vomitus, or the soft tissues of the pharynx. It may stimulate the vagus nerve, which slows down the heart rate. It can end up in the esophagus. It can cause gastric distension. It end up there. May cause a spasm of the larynx and result in vomiting if inserted into responsive patient. Should not be used when pediatric patients have facial trauma because the airway may tear soft tissues and cause bleeding into the airway. Oxygen delivery devices. Several options for pediatric patients. Blow-by technique at 6 liters per minute provides more than 21% oxygen concentration. And that's going to be more for your newborn, neonate infants, your younger pediatric population. Nasal cannula 1 to 6 liters per minute provides 24 to 44% oxygen concentration. Non-rebreathing mask at 10 to 15 liters per minute provides up to 95% oxygen concentration. And the BVM at 10 to 15 liters provides nearly 100% oxygen concentration. Non-rebreathing mask, nasal cannula, or simple face mask is indicated for pediatric patients who have adequate respiration and/or tidal volumes, but they are showing signs of difficulty breathing. BVM is used for those with respirations less than 12 breaths per minute or more than 60 breaths per minute and altered level of consciousness or inadequate tidal volume. Blow-by method. Less effective than face mask or nasal cannula for oxygen delivery, does not provide high oxygen concentration. Administration: place tubing through hole in bottom of a cup, connect tube to oxygen source at 6 liters per minute, hold cup 1 to 2 inches away from the nose and mouth. Nasal cannula. Some patients prefer the nasal cannula, some find it uncomfortable. Applying a nasal cannula, choose the appropriately sized nasal cannula, connect tubing to an oxygen source at 1 to 6 liters per minute. Non-rebreathing mask delivers up to 90% oxygen, allows patient to exhale all carbon dioxide without rebreathing it. Applying a non-rebreather mask, select appropriately sized mask, connect tubing to oxygen source at 10 to 15 liters per minute, adjust oxygen flow as needed. Bag valve mask, indicated in patients with too fast or too slow respirations, who are unresponsive or who do not respond to painful stimuli. Assist ventilations with a BVM, select appropriately sized equipment, maintain good seal and mask on the face, ventilate at the appropriate rate and volume using slow squeeze. 2-person BVM, similar to 1-person BVM. Ventilation except one rescuer holds the mask to the face and maintain the head position. Usually more effective in maintaining a tight seal. Cardiopulmonary arrest in pediatric patients is associated with respiratory failure and respiratory arrest. Children are affected differently by decreasing oxygen concentration. Adults become hypoxic and the heart develops a dysrhythmia that leads to sudden cardiac death. Children become hypoxic and their hearts slow down, becoming more bradycardic. Shock, a condition that develops when the circulatory system is unable to deliver sufficient amount of blood to the organs, resulting in organ failure, eventually cardiopulmonary arrest, compensated shock in the early stage of shock. That's when everything is still up. Decompensating stage is when the blood pressure starts to fall. But in your pediatric population, you're paying attention to the pulse. Is it tachycardic or is it bradycardic? It's a young pediatric population with a bradycardic pulse. That's an ominous finding. Common causes of shock include trauma injury with blood loss, especially abdominal, dehydration from diarrhea or vomiting, which is very common, severe infection, neurologic injury, such as severe head trauma. And this is the point at which